Hello, good evening, everyone. Welcome back to our session 3 of the Mind the Bleep IMG series. We're conducting this PLAB 2 mocks. Thank you for everyone who has attended our previous sessions, and welcome to those who's first attending the session. So just a quick introduction about this PLAB 2 mocks. We'll be running through some teaching in the beginning of the sessions, and then we'll have 3 mocks which is tailored to our PLAB 2 exam. So anyone who would like to be volunteers, it would be much appreciated, and we will give some feedbacks at the end of every stations. So just a quick introduction. My name is Dennis. I'm currently an F1 working in the Portsmouth General Hospital, having passed my PLAB 2 last year. So I was quite lucky to pass all my stations. So I've done a lot of mocks for other people as well. Hence, I feel like I need to share this experience with everyone. And with me, I've got Amanda. Would you like to introduce yourself?
Yes, hi. Good evening, everyone. My name is Amanda. I work as a junior doctor at an F2 grade. I work at Stepping Hill in Manchester. I passed my PLAB 2 about a year and a half ago, so it's been a while. And I think I missed maybe 2 stations, so I'm not maybe as good as Dennis. But we'll try to do a good job today, trying to give you an idea, a mock idea of what the exam would be like. I think I'm going to be a patient for most of your stations, and I think Dennis will lead with the teaching.
Okay, and we have got our IMG lead for Mind the Bleep, Razaz, there in the background with us as our facilitator. All right, so just okay, she's back.
No, it's fine. Continue. I'm just here in the background. If anyone would love to volunteer, please send messages in the chat, and I'll add you to the. I'll invite you to the stage as soon as we start doing cases. Thank you.
All right. So just a quick run through and just an overview of what we're going to do tonight. I will be discussing mainly about segment, where most people struggle, because I do struggle with that stations as well. The main reason is time management, where there are 8 minutes and we struggle to finish everything off. So I'm going to give you the structured approach towards the stations and what you need to do. And essentially, everything's going to be the same once you follow the tactics, the management that I'm going to teach you tonight. And I'm going to speak a little bit about the combined stations as well, because it seems a bit popular. So what is the combined station? Essentially, it will be history taking, clinical examinations, and a quick management. Just a quick summary. A lot of people, for those who first attended the session, I'm sorry if it's just a bit repetitive. I'm going to run through what you will be expecting during the exam itself. So during the exam, you go in there 16 stations where you have 1 minute 30 seconds in front of each room to read the prompt. When I say read the prompt, is you have to actually read them, run through every single questions in your mind, what the differential diagnosis are, what the management in, so that when you go in, you're more structured, you're more confident of what you're going to ask, what investigations you're going to take from them, and what management you're going to do. Rather than just wondering about not knowing what to do during the 1 minute 30 seconds, I want you to actually read the prompt, because I would say about 50% of the stations, they will tell you on the prompt, if it says take detailed history, address the concern, take detailed history, management, and address the concern. So you have to do all these 3 things. But in some of the psychiatry stations, it will just tell you talk to the patients and address the concerns, where you know that you actually have to perform well in your interpersonal skill, where you actually have to listen to them, to talk to them. So in the combined stations, this is tiny tip that I would tell you is just to take a peek into the room, where they will have a little tiny windows at the side. So you can just take a room. If the room is slightly bigger with something close covered, then you know it can be a combined stations, or if there is a mannequin lying on top of the table. So you would know. And on the prompt itself, it would tell you, take history, take focus history, or just take history, do the clinical examinations, and tell the patients about what management you're going to do. And you would know there will be clue on the prompt telling you what to do. So in stations like this, I would do a quick run through of the most important questions. I wouldn't be bothered about everything like family history. Do you have any allergy? If it's not relevant, don't ask. Just go in, tell me a little bit more. Start with open-ended questions, because the simulators, they are mostly very nice. So they memorize the script. They would tell you what they are experiencing, what the complaints are. So it will save you a lot of time running through every single thing. Like Socrates, if they tell you the first 5, it started suddenly, when did it start? So you don't have to ask those close-ended questions again. So just ask the red flags as well, any wet loss, any night sweats, and just the important question that you have to ask, any past medical history, any regular medications, and that's it. If social history is not relevant, you don't have to ask. In the combined stations, time is essence, where you actually have to ask targeted questions at the examinations that you need to do. Or if the patient say, for example, they have got a breast pain, abdominal pain, so you have to ask targeted question based on around those symptoms. I hope it does make sense. And the reason that I'm talking about Seaman and this A2E assessment as well, if you're unsure of what you want to do, you can always run through the A2E assessment. Because in the PLAB 2 exams, what they want you to do is just how to be a safe doctor, how to be empathetic, and how to practice basic medicine. You don't have to come up with some brilliant management, because consultant can do that. It's just an F2 level. So you just have to practice on the F2 level. Where you be a safe doctor, you're not killing the patients, you refer or you talk to the seniors when necessary. So in most of the stations, what would make sense is you treat the symptoms, you order the necessary investigations, and then you tell them, I'm just going to talk to my seniors to see if they have anything else to add. So that's pretty much it. That's your management cover. But how does interpersonal skill come in? It would be how you approach the stations in general, how confident you are, how you walk into the stations, you make eye contact with the patient, you smile to them. Every single, even the most subtle details, they will score you in interpersonal skill. They don't want you to be like a robot, because if you go to an academy, they would just chuck loads of scripts at you, ask you to memorize them, and come up with investigations, management. If they're in pain, say sorry. So that's the reason why a lot of people will fail the first attempt in PLAB 2. Hence, that's my personal experience as well, because I would just go in, I would treat it like my actual patients, where I would chat to them. I address the concerns when necessary. You don't actually have to say, I'm sorry, just say, oh, bless you. That sounds really difficult. I can't imagine putting myself in your shoes. You can just say something like this, be empathetic, make the patients more comfortable. If the simulators are comfortable with you, they would help you. So they will give you more clue to the stations, more keys to the stations as well to help you with the diagnosis. So when you refer them appropriately, just treat, oh, I'm in pain, doctor. Don't worry, I'll give you some painkillers, and make sure the patient is clinically stable. Send off do some basic clinical examinations, take observations, listen to the chest, inspection, palpations. They are not rocket science. And just say, I will order whatever scan that's necessary. And I'll just do the blood test. I will refer you to if you're nauseous, I'll give you antiemetics, and I will just speak to my seniors. That's pretty much it. So I'm going to move on to the Singman stations now. So I'm going to give you a quick overview of what the stations will be like, because some of you have no, it will be your first examinations where you've got no clue of what you'll be expecting. So you will see, when you go into the stations, you will see a seaman, a mannequin lying there with the examiner at the side. So you just tell the examiner straight your your name and your GMC number. Let's not waste any time. And then he will tell you can begin. So you go to the patients quickly, just say, hi, my name is, let's say for this case, I will just use Mr. Andrew Smith. So, hi, my name is Dennis. I'm one of the junior doctors here. Can I just check your name and your age quickly? So you can, if the patient is not answering you, you can always look at the wristband. But normally in the Siemens stations, because they are quite fixated of a few stations where they normally come up, where I will go through each of them later. So the patient will say, oh, Andrew Smith, I'm 78 years old. I'm in pain, doctor. So most people think, where did the interpersonal, how do I score in interpersonal? If they tell you, I'm in pain, doctor, just say, don't worry, Mr. Smith, I'm here to help you, but let me just do a quick assessment to see what's going wrong. So you can carry on with the stations. Mr. Smith, since you are talking, if the patient says, I'm in pain, or just grunting noise like, oh, help me, help me. So you know, you start with A. If you look at my slides, you start with A, where you see, if Mr. Smith, since you're talking to me, I'm not worried about your airway, or you can just say your airway will be patent. Let me just have a quick look at the monitor for you. Some people, some approach to the stations will be you take a history first, and then you do your assessment. But sometimes I didn't do that is because I would strongly advise you to take history later, because when you start asking questions, you would fall into the trend of taking the full history where you waste too much time rather than actually managing the patient. So I would look at the airway first, because that would be the most important thing as well. If the patient's airways collapse, doesn't matter. If you ask any questions, they're not going to answer you. So just say, if the patient is answering you, airways patent. However, if the patient is not answering you, GCS is less than 8, you can say, I will need to call the anesthetist to come and intubate the patients. But in PLAB scenarios, in the PLAB world, it's not going to happen, because they want you to do the full assessment. So in most of the stations, patient will answer you. So just say, Mr. Smith, since you're talking to me, your airway is patent. Let me just have a quick look at the monitor to see what's going wrong. So you move on to B. What's your B? It will be your breathing. So you will be essentially looking at your respiration rates and your saturations. There will be on the screen for you. So in some scenarios, if you have to manage them as you go. So if the saturations is low, you can just ask the patients quickly, do you have COPD, or are you smoking, sir? Are you a smoker? If not, you can target the saturations at a higher level, where you can just you can just say, your oxygen level is a bit low, Mr. Smith. I'm going to give you oxygen, where you actually have to go to the crash trolley. On the crash trolley, there will be A to E. If you're not familiar with the crash trolley, I would advise you, when you go to the academy, look through the crash trolley, because everything is there. So if you're going through breathing, so it will be in B, where you have to put in 15 liters via non-rebreather mask. You actually have to take the mask, pick the right mask, put it on the patients, and then you have to adjust the oxygen. So and then you can move on to, right, Mr. Smith, can you tell me, then you move on to history taking here, because you have already made sure the patient is stable. He's not going to die imminently, so you can take history. So for example, you can say, Mr. Smith, can you tell me what happened, or what brought you into the hospital? Then you take a quick history. I'm having shortness of breath, or I'm not feeling well. So you can ask a quick one. If the patient's in pain, you can ask the Socrates, but just a quick one to help you with management, not the full history. I will just run through a quick, do you have any other medical conditions, or have you had recent operations? If not, you can look through on the table, at the side of the table. Sometimes there will be inhaler at the side. Sometimes there will be some medications. In the anaphylaxis stations, where there will be a bag of blood transfusion running through. So you have some clue of what's actually happening. In the post-operative bleeding, you will actually see an operations note, where you need to just have to take a quick look through what the patients had. And then you move on to, let me do a quick examinations on you, Mr. Smith. So you do your basic respiratory exam, where you have to do the inspection, palpations, percussion, most importantly, auscultation. In B, auscultations will be the most essential part, because in the semen, you can hear crackers, you can hear wheeze. So if any stations which is dealing with respiratory problem, you will actually hear the findings. So with palpations, you can just do a quick one to do, you can do percussion. And then you have to do the general inspection will be look at the patients to see if the patient has got any cyanosis. But that's it. So if you hear crackers, if the oxygen level is low, if you hear wheeze, you manage them. You just say, I can hear some wheeze, let me give you some salbutamol. And you actually have to go to the trolley, get it, and give it to the patients. And examiner would tell you when to stop if they want you to. And then after that, after clinical examinations, let's do systematic one. Move on from clinical examinations, move on to investigations, where you have to do ABG and chest x-ray. That's the basic one. Just say, Mr. Smith, I need to do a quick bloods from arterial blood gas from your vein, from your artery, or from your little veins on your wrist. Or you can just say, I will just book a quick chest x-ray for you. Then you move on to C. So once you're happy with B, you realize you feel like the patient is stable, you have done whatever that you want to, then you move on to C, because breathing is more important than circulation, so that you don't kill the patients. So when you're moving on circulations, let me have a quick, you can just say the quick sentence. Just tell the patients what you're going to do next, because the examiner is listening as well. Rather than verbalizing, looking at the examiner, they want you to tell the patient so that you can get your interpersonal skill. Mr. Smith, let me just have a quick look at the monitor again for your heart rate and your blood pressure. And that's it. So you look at the blood pressure, you look at the monitor, you look at the blood pressure and the heart rate. Sometimes the blood pressure will be very low and heart rate will be very high. And in the sepsis case, or in a bleeding case where those are relevant, where you need to do cannula. But in all cases, I would say just save your time thinking if you want to do cannula, do them. When it's in an emergency scenarios, you do the biggest goals. You can say, they will actually ask you what cannula you want to do. So you go to the trolley, take out either an orange or a gray cannula. If the patient is having severe hypotensive episode, it's better to put 2 of them. If there are signs of bleeding, then you just need to put 2 of them, give them as much fluid as possible. If not, just do a quick fluid challenge. So after the cannula is put in, just say, I will take some bloods as well, because just send off the routine bloods, your FBC, your USNE, LFT, your CRP, and group and safe if it's necessary. But in an emergency case, if you don't want to think too much during the exam, I would say you do everything, because you're not going to lose marks for doing more things than you needed. So just say, I will send off some bloods whilst I'm doing the cannula, and just tell the patients, I'm just going to do a routine blood test, and that's it. If you want to do the fluid resuscitations, you have to take out the fluids, what you want to do. In NHS, normally we use a sodium chloride or a Hartmann solutions as resuscitation fluid. But I would say pick your fluids, pick your favorite, and stick with it, so that you don't actually have to think or confuse yourself during the exam. So your blood pressure is a bit low, Mr. Smith. I'm going to give you loads of fluids via the cannula or in your veins. So just tell the examiner would ask you. If you don't say it, examiner will ask you, but just say, I will give you 500 ml over 15 minutes. Or you can, if patient has got history of heart failure, you just have to give it a bit slower, 250 ml over 15 minutes. And then you move on to the next one, where if you're happy with C, and then you can move on. But if you're not, in cases like acute limb ischemia, where the patient is hemodynamically stable, you can always say, I'll give you some maintenance fluid back over, for example, 8-hourly or 12-hourly back, depending on yourself, what you like. But if patients is hemodynamically unstable, resuscitate them with fluid straight away. Because once you have done those things, you can actually see on the screen that everything, the patients, the vital signs would actually be normalized or improving. And then if you're happy with C, if so you've done the basic, patient is stable, what you're going to do, you're going to do examinations, you're going to do investigations. In C, what examinations will be most relevant would be you just have to feel their heart rate, you have to feel their pulse, you have to check for capillary fill time, and you have to auscultate their heart sound. Nothing extra, nothing complicated. And that's it. Look at the skin color, skin temperature, just a quick feel. So for any clinical examinations, not just for Sigmund, even in the combined stations, you have to start with inspection, palpations, percussion, auscultations if relevant. So if you have this in your brain, fixated, memorized it, and any stations that come out, even if you are nervous, you know, oh, right, fine, I need to start with inspection first, then you know what to do, and you move on to palpations, percussion, and auscultation. So that's it. In C, so you have to touch the patient quickly. You can do a central capillary fill time. You can check the pulse volume. For these, I'm not going to ask you to memorize what we are exactly doing. So you can just follow your own pattern, what you're most comfortable with. Some people would be more comfortable feeling the pulse first and then check capillary fill time, check the skin temperature. But you can do, especially with skin temperature and your capillary fill time, you can do it at the same time. So what you find out, the examiner will tell you capillary fill time less than 2 seconds or pulse rate is normal. But if you're auscultating, you can actually hear the heart sound because that's how great the Siemens are. So if you're happy with C, you feel like, okay, fine, I'm going to move on to D now. In D, I've got a mnemonic where I normally use. It's called CPCR. Because there's so many things in D where you tend to forget, especially if you're nervous. So in D, just have to go systematically with 4 things. C, consciousness level. Patients can be alert, responding to voice, responding to pain, or unresponsive. So that's your C. That's your consciousness level. P will be your pupil size, where you actually have to take your torch and then shine it into the eye. You will be surprised to see the pupils are actually reactive. And then you move on to CPC. That will be capillary glucose. That you need to just do a quick BM. Just say, Mr. Smith, I'm going to do a quick blood glucose test on you. It's just a finger prick one. And then R. What R will be the most important one, where it's called review, where you have to go back to A, B, C again to make sure the patient is stable before you do anything else. Because in the Siemens stations, they will want you to stabilize the patients because this is what is expected of the junior doctors. So go back again, Mr. Smith, let me just have a quick look at the monitor again. Or you can just say, how are you feeling now, Mr. Smith? Or I look at the monitor. So if you manage the patients well, you would actually see improvement. So in the breathing part, the respiratory rate will come down. If you're giving patients oxygen, the saturations come out. So if you're quite happy with that, fine. And in the C station, if the blood pressure is coming out after your fluid resuscitation, then you can just stick to that. If it's not coming out, just say, Mr. Smith, unfortunately, your blood pressure is still a bit low, so I'm going to give you a little bit more fluid. So you give another 500 ml over 15 minutes, and then you move on. So if you're happy with D, so that's fine. You move on to E, exposure, where you actually have to look the patient from toe to tail, from head to toe. Sorry. From exposure, I would say you just do a quick abdominal examinations, listen to the abdomen to see if there's any bowel sound, or you have to look at the private genital area. But in this PLAB 2 well, or you can look at the legs as well. But in PLAB 2 well, what will be relevant to E would be if the patient has bleeding, you will see a pad on the bed where you will see bloods on it. So that will be the most relevant one, most important one you need to know in exposure. Right, fine. Now you have got your A, B, C, D, E. If you are quite happy, if the patient is stable, you can ask, how are you feeling now, Mr. Smith? I'm feeling better now. Right, so you're gonna explain to the patients what they have. I think you might be having this asthma, or you might be having septic shock. So you can talk about further findings or further investigations you want to do, and then you can present to your seniors. In some stations for seamen, they will ask you to present to the seniors, where the examiners will be your seniors. So you need to do an S-bar approach. But if they say, in the prompt it says manage the patients and then talk to the seniors, and then you need to run through the A, B, C, D, E rather quickly. Give yourself about a minute or so to speak to the examiner. But when you're speaking to the examiner, like how you would refer the patients to any specialty, where you do the S-bar approach, which is commonly used in the UK, where it's situation, background, assessment, and investigations, referral. So you just say, we've got this patient who's admitted with shortness of breath. I think she's got asthma. And then you tell the examiner, run through with them what you did so far. That's pretty much everything. So in terms of seaman stations, there are a few stations that I would say normally would come out during the exam, because this is the scenarios where we normally encounter as a junior doctors anyway. So for example, asthma. So now from now on, I'm going to give you a more specific investigations or more important management towards these specific stations. So asthma will be a good one, where you have to give salbutamol. Read through what dose you're going to give, 5 milligrams of salbutamol via nebulizers. Just know the important one. If it's not controlled, you can give IV hydrocortisone. So I'm not going to go in details of every stations, but run through these scenarios and see what's the most important one. For asthmatic patients, if they're not well, you can always give magnesium sulfate, but speak to your seniors first. And then the second station will be anaphylaxis, where they will have blood transfusion, or where the patients can't breathe with low saturations. You need to give adrenaline. They will ask you how much adrenaline you're going to give. So you need to know those things as well. And the third stations will be hypoglycemia. You need to give them glucose. You need to manage them at D. If you don't realize that the blood glucose level is 1.2, so you just need to give 10% of glucose, or 20% glucose, 100 ml. So it depends. And the third stations will be the bleeding station, where it's either postpartum hemorrhage, post-op bleeding, upper GI bleed. So that will be your bleeding stations, where patient is extremely hypotensive, where you have to give them loads of fluids. In that stations, you would say, I need to put in 2 cannulas, and I'll give you a liters. A liters of fluid initially will be the max that you can give, and will be recommended to give as well. And the next station will be the popular one, which is sepsis. So if you can do the take 3, give 3 protocol in sepsis, you're better than most of the candidates, because this is what they want us to do as well. So take 3 will be blood culture. It will be blood culture, urine output, and what's the other one? Lactate, yes. And then give 3 will be antibiotics. You give IV fluids, and the other one, yes, that will be it. So the next station will be quite a stable one. That will be a more systematic approach, like when you are taking your normal history. So there will be post-operative pain, where you actually have to manage the patients. give them some morphine, and that will be all. But you have to run through A, B, C, D, E as well to tell the examiner what you were doing and how you're stabilizing the patients. And the next one, the last one, which is quite rarely that comes out during the exam, will be hospital-acquired pneumonia. That will be everything where you just have to give antibiotics. And that's it. That's the Sinman station done for you. Any questions so far about Sinman? Well, I don't see any questions in the chat room. We're gonna move on. So now we're gonna move on to the mocks now. I think Patricia here would like to be the first volunteer. Hello.
Hi, hello. Can you hear me?
Yes, everything's okay. So
Hi, hello. Can you hear me? Sorry.
yes. Can you hear us?
We can hear
okay?
you. Yeah.
I think I'm here.
Hello.
Hello.
Hello. Can you hear us? Okay. Hello.
Hello. Oh,
Hello. Can you hear us now?
I can hear you now. Sorry. Oh, I think it's
That's
working
brilliant.
now. Is that okay?
All right, that's fine. So our
Yeah.
first station tonight, our stations tonight will be our cases tonight will be on a combined stations, which is quite popular in exam now. Where recently I've heard you get 2 or 3 stations in your exams. So like I've mentioned, for the combined stations, just remember a quick targeted history, get your red flags, do clinical examinations. But unfortunately, because it's virtual, so we don't have the mannequin. But I will want you to run us through what you're gonna do, like inspection or spatial test that you're gonna do. Then I will give you the findings during the clinical examinations, after the examinations, and then you tell us the management. So are you ready?
Yep.
Like
That's
usual, I will give you 1 minute 30 seconds to read the prompt, to go through everything. Okay.
I'll give you the advice that the GMC, there was a person when you go for your PLAB 2, who comes in and sort of introduces herself on behalf of the board. And she gave us this advice right before we went into the exam hall. She said, read the prompt, and if you want to pass the station, read it again. Okay?
Yes.
So just focus on that.
Yes. All right.
So
So
sorry, I didn't hear the last bit. So if you want to pass the station, what?
You read the prompt, and if you
Yeah.
want to pass it, you read it again.
Oh, I see. Yes.
Okay. So I will start the timer 1 minute 30 seconds, and good luck.
Thank you.
Begin. Enter the room.
Okay. I'm Patricia Costa Carrasco. My GMC number is 76994331. Hello.
Hello.
Hi, hello. I'm Patricia. I'm one of the junior doctors working in this department. May I confirm your full name and age, please?
Yeah, I'm Selena Gomez. I'm 44 years old.
Okay. How would you like me to call you?
Selena's fine.
Nice to meet you, Selena.
Hi.
How can I help you today?
You know, doctor, I'm just really freaked out. I was in the shower this morning, and it was just a normal day. I was just going about it, and I just went for a quick shower, and I felt like there was a bit of a lump in my left breast. And I've always read that these things are quite serious, and so I just thought I should see my doctor right away.
Okay. Yes, very well to coming to us, and we're gonna help you today. We're gonna check on you. So Selena, before we move on, I would like to know. So you noticed it today when you were having a shower. Could you tell me a little bit more about the lump or your?
I mean, what would you like to know?
Well, you said I was on the left. Is it one lump or maybe more than
I
one?
can, as far as I've felt, yeah, it's one lump. It's on the left side. It's quite small. It's not too bad. And I don't think it hurts me or anything because I didn't even notice it until this morning. But yeah, it's just there, and it's really like, I don't know what it is. Can you tell me what it is?
Yeah, we definitely can advise you, and but I would like to know a little bit more, if that's okay for you.
Yeah, sure.
Yeah. So I would like to know as well if it's painful.
No pain. As I said, I didn't even know it was there until this morning.
Okay, and well, you said you haven't noticed it before. Could you describe the lump for me? Do you feel it hard or it's more like soft?
I would say it's a bit hard. Yeah.
Mhm.
And it's just there. I don't know.
That's
And it's
right.
small. It's not too big. It's not. Yeah. It's not something I
Okay.
noticed until today.
Have you noticed any redness on the area?
No redness.
No. That you feel warm on your chest? Oh, sorry. Yeah.
No,
Warm.
not really. No.
And have you noticing any like like liquid or coming from your breast or any fluids?
No, not particularly. No,
Okay,
I wouldn't
that's
say
good.
that. Yeah.
And what about the other breast? Have you noticed anything else on that one?
I did kind of feel right away. But I didn't think that there's anything in the right one.
Okay.
But I think a doctor should probably examine because I didn't feel it, but I'm not a doctor.
Absolutely, and yeah, if you're happy, yes, I would like to have. If you're okay with that, I would like to examine you. But before that, I just want to know: do you notice any changes in size of your breast?
No, not really. I would say that it's pretty much what it normally is.
Okay, okay. And apart from this lump, have you noticed anything else?
Um, Honestly, I feel like I'm okay, but you know, my partner has been telling me that they feel like I've lost a little weight recently.
Mm-hmm.
I think I've just been going to the gym more often, so I really don't know. But he just tells me off and on that he thinks my clothes look a little bigger on me, and just my face, it just looks like I've lost some weight, but not quite sure.
Okay, okay. And how you feel, but your appetite is still the same? You're still eating the same things?
Pretty much eating the same things. Yeah, I've just been because I go to the gym more often. I've just been watching my diet, but overall, yeah, nothing's changed.
That's okay. And what about smoking? Sorry.
I do smoke off and on. Yeah.
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 Okay. And and what about your drinking and alcohol?
I drink socially with friends and family and things, but it's not like I binge or anything. I think, yeah, just the usual.
That's okay. Any medical conditions that you are aware of?
I have low thyroid, so I'm on tablets for that. But other than that, I'm okay.
Okay. And do you take your tablets regularly?
Yeah, I'm quite regular with my tablets. Yeah.
Sorry, would you
good.
like to carry on with the examinations?
Yes. Okay. Sorry. Well, Selena, if you're okay, I would like to examine you. The process will be you would need to be exposed from your waist to the top. And I will have a chaperone with me to protect your privacy. And the examination itself will consist of me having a tender. Well, I need to palpate the breast area, and I need to palpate the armpit area as well. Would that be okay for you?
Yeah, doctor, whatever you need. I really want this checked as soon as possible.
Yeah, that's okay. So what I would do is I would like my patient to expose that area. I will compare. I will inspect both of the breasts to check for any asymmetry. I will ask her to sit down on the bed, and then move the arms at the back of the neck. Then I will ask her to put the hands together. Sorry, and then I will assess. I will have a look, and then I will ask her to put her arms on the waist as well, and then to lean forward a little bit just to see any changes as well. Then after the inspection, I will proceed with the touch. So I will go to. Okay, this is tricky. Sorry. So I think I will go for the left side. Ideally, I will go for the left side first, and then I will move on to the right one. But for the exam purposes, I will I will go directly for the left breath, and I will start in a circular way, and then I will avoid to touch the nipple area. And I will try to do like light touch, and then to press a little bit harder,
Time's up.
and then sorry.
It's okay. Do you want to just give your management plan?
Yeah. So sorry, any findings from the
findings first. It's about 3 centimeters, irregular in shape, attached to the skin. Will feel some tenderness, and it's a bit warm as well.
Okay. Well, so that will be for me just a suspicious lump. So we would need to do further assessments, and that will involve to have the patient to go for. Well, we need to. She's 44, so I think it can be a mammogram. So she would need a mammogram. She would need a biopsy, so we can have a better idea of the lump. I forgot to say that I will also check the neck just in case there are other lumps somewhere else. And then I will refer the patient with, well, depending on the results, I will refer the patient or consider the patient to the, I think there is a breast clinic or breast cancer clinic for assessment. She will need to have a full medical assessment with full medical history and full examination. And she will also need to have some more investigations, which will include some blood tests. And then sorry, maybe a bit disorganized.
That's good enough.
No, you're doing fine. Just continue.
You're doing fine.
Yeah.
Just carry on, please.
And then, okay, I will also discuss this case with my senior, and I will recommend all this. This will be my recommendation. These are the things that we might do. So I will discuss this case with my senior to make sure that this person, that my senior is happy. And then I will also check. I didn't check right now, but I could tell that the patient was a bit anxious about this. So also maybe some support, maybe refer her to the nurses, the nurse specialists, the nurse practitioners, so they can give some more information about this, and they can be aware of this. And then I will safety net my patient and follow up definitely. So I need to see this patient again.
Yeah. So
I think
you're doing too well, I would say, because you've covered too much.
it's such a short time. I know.
You've got 8 minutes, so you need to be really careful
Yeah.
with your history taking. That's the reason why I've always say, if you go in, if you see the mannequin, or if you see a hand there where you need to take bloods, you just have to be quick with your history taking. Just ask. I will go in, ask about the lump. Tell me a little bit more about the lump. When did you notice it? And then you ask about the red flags, where any wet loss, did you notice any discharge? And then you move on, any family history. I mean, you don't actually have to ask if you're smoking, but just ask the relevant history, because you will take about 4 to 5 minutes to do a good clinical examinations. So for the breast examinations, it's all right if you miss one or two things, but it's most important, like I've mentioned just now, inspection, palpation, percussion, auscultation. In this case, you need to do a really good palpations, and you have to check the lymph node, which you did. That is brilliant. And you did the right management where you know to refer the patients. So this in the UK, there's something called, if for any cancers, any suspicion of cancer, you can refer them to the 2 weeks wait pathway. Where they will
Yes.
in 2 weeks. So in cases like this, remember you have got 8 minutes, and I appreciate 99% of the candidates will struggle with their management. That's why people struggle with combined stations, because you will spend too much time taking history. It's fine if you miss one or two questions, but you just have to get the most important ones, if it makes sense. All right. Any questions?
Yes. Maybe just when do you know how to switch, like when or how to do more nicely? Because I feel like I'm interrupting something and then I need to move on to the mannequin.
Yeah, this is why your systematic approach comes in. You take the history, the complaint, and then the red flags means your differential, family history, past medical history, medications history, family history if relevant, social history, and then you move on. Right. So for this case, Mrs. Smith or Selena, thank you for telling me all these. I'm just going to do a quick examinations to see what is actually going wrong. Then you explain the procedure which you did, and you did offer chaperone, and you asked for consent. I would always, in any cases, I would always say, if it makes sense or any questions so far, just to check their understandings, or if they've got any concerns, if you've got the time. So in this, it's more time constrained in the combined stations, where you just move on to clinical examinations, because that's where the weightage of the marks is for that stations.
I would just add something to that. When you go into a combined station, right, and you're seeing this prompt in the front, right before you enter the room, you see the last line. It's asking you to take a focused history, do relevant examination, and discuss management. So when you know that there are 3 things you're going to be assessed on, you want to touch those 3 things, because you're going to be marked on all 3 things. So it doesn't matter if you've taken the best history, but you don't finish, or you're rushed with your examination, or you don't get to your management. So that's how you'll know where to stop and you know how much to rush, because you might think you were doing this, you were doing that, but actually you did everything. You took the right history, you gave a good examination, and you had a good management, but you didn't get to it. So don't try to dwell on one thing and try to make it perfect. When you know the questions asked you 3 things, just move on, because it's not going to look rushed. You're going to feel rushed, but you're getting to the 3 things that were asked in the question.
Okay.
Okay.
Thank you. Yes.
Any other volunteers for the second station? It would really help with your confidence and your flow during the exam if you are able to practice in front of an audience during an exam. It's just going to be yourself, simulator, and an examiner. You'll be like, what to be scared about? I've practiced in front of so many people. So I think it's a good exposure. So any other volunteers? Would you like to do it, Patricia?
Sure. Yeah, we can go for it.
If you don't mind.
Yeah, that's okay. Yeah.
All right. Thank you. So second case.
Begin. Enter the room.
My name is Patricia Costa Carrasco. My GMC number 76999431. Hello.
Hello.
Hello. I'm Patricia. I'm one of the junior doctors working in this department. May I confirm your full name and age, please?
Yeah, doctor, I'm Daniel. I'm 23.
Okay. Is it okay if I call you Daniel?
Yeah.
Okay. Nice to meet you, Daniel. How can I help you today?
Doctor, I have severe pain in my testis, and it's been there for. It's just started recently. It's been there for about 2 days, and it just hurts. It started off as just like a pain that I ignored for a bit, but now it's just getting worse. I don't know what to do.
Okay. Sorry, Daniel, are you in pain right now?
Yeah, very much.
Okay. Is it bearable? So I can continue because I need to ask some questions. Is it bearable for you right now? So
Yeah, I think so. The nurse has just given me a painkiller. I'm fine, but I really needed to be checked.
yeah, that's okay. So you mentioning that you noticed it this 2 days ago and it's getting worse. Could you tell me a little bit more about this pain?
Yeah, like it started out of nowhere really. I wasn't doing anything. It's more on my right side. And 2 days ago I noticed it a little bit, and I just felt like it was a muscle pull or something. It was not even that bad. And now it's so painful and I don't know what to do, and it's just been increasing. I've not done anything to make it better or worse. Nothing I take at home has helped, and I'm quite worried because this is not it's not usual for me.
Yeah. Yeah, yeah, I understand that this might be a very frustrating situation, but we're here to help Daniel. So just bear with me a few minutes. I just need to know some things. Apart from this pain, do you have any other symptom?
I mean, I feel like I've just been run down the last 2 days. I haven't really done much that I used to do. I don't know. I feel like maybe I have a fever, and I've just been really unwell. But I live alone. I don't really have a lot of people taking care of me. I don't know. I've just been really unwell.
Okay. And do you notice any changes in size in your testes?
I feel like there's a bit of swelling on the right side, but not too much. But it's more the pain, and it's more like how it's affecting me overall. I just feel really unwell.
Does the pain go somewhere else, or it stays there?
No, it's pretty much that.
Okay, and yeah, you mentioned that nothing makes it better. That you're right. Is there anything particular that makes it worse? Any position?
No, nothing.
Okay. And if you could score your pain from 1 to 10, being 1 no pain, or and then 10 the worst pain you ever felt, how will you score it?
Maybe a 6 or a 7, I would say.
Okay. So you mentioned that you might feel a bit warm. Apart from this, have you noticed anything else?
No, I just said a little bit of redness and a little swelling down there, but overall nothing much.
Okay. Okay. Any discharge that you noticed from the area?
No, not exactly. No.
Okay. Lumps and bumps?
No, nothing.
Okay. Right. Okay. Very well. So I would like to, if it's okay for you, Daniel, I would like to examine you.
Yeah. Okay.
Yeah. So
are you going to do anything invasive or just going to examine me?
No, sorry, it's not gonna be invasive. So what I'm gonna do is, so I need to examine the area. For this reason, you're gonna be exposed from the waist below, and I might need to I need to palpate as well the area. I will have a chaperone with me to protect your privacy. How does this sound to you?
Yeah, that's okay.
Yeah, and also Daniel, if it's painful, I will stop at any point. Yeah, so just please let me know. Tell me if it's too painful. I will just stop.
Yeah.
Yeah. Okay. So what I would do is I will expose the patient. I will inspect the area looking for any abnormalities. I will check on the size of the testicles or if there's any visible thing. Then I will move on to palpation. And then I will start. Well, this is very sensitive area. Sorry. So I will start from the
2 minutes remaining.
Yeah, so I will start from the inguinal part, inguinal area, just to check for any lumps and bumps. Then I will check. Probably I will go for the left testicle first. I will try to touch it to find, to identify the components of the testicles and to check for any inflammation. I will go for the right side as well, very gently, and asking the patient if it's okay. And I will try to identify as well any pain or anything in there. So, okay, I think so that's what I would do.
Okay. No lumps that you can identify, but when you lift the scrotum out, it's the pain is relieved by elevating by testis.
Thank you. Okay. Well, Daniel, thank you for let me examine you. So from what we discussed and what we have done so far, it seems to me that you might have an infection in your testicles, something that is called epididymitis. Have you heard about this before?
No, doctor, and I'm not that kind of a person. Is this like something I should be worried about?
And
have I got
yeah.
it from someone else or what?
Oh, sorry, apologies. I couldn't hear that part. So,
I just said, is this something I should be worried about? What kind of infection?
yeah, and this is a very valid concern, but we might need to run further tests so we can identify the cause of your infection. If it's all right with you.
Move on to the next station.
Time's up.
Yeah. It's challenging.
It's not the
You-
easiest. It's not
you
the
did
easiest case. Yeah.
Yeah.
No, yeah, thank you.
So how did you think about how you did?
Well, I skipped a lot of things. I wanted to do like a more focus, but at the same time, I think I was trying to follow the patient's lead, what they were telling me. And then I think because the time I wanted to go to the examination, and then when I got to the examination part, I also skipped some steps. So probably should have asked the patient. I think they do like standing and then laying down in bed. I forgot to do the cremasteric reflex. So yeah, I made some parts in there. And then in the management, well, I didn't have the time to carry on.
Yeah. So I think you did a good history taking. I have no problem with your history taking at all. But in this case specifically, because it's a suspicion of infection, it can be STI. So you need to ask about sexual history. But I would not ask the rest of the things. I feel like in PLAB 2 exam where you're actually you're a doctor, so you don't. I feel like you're too nice. Like you're constantly asking permission where it's time consuming.
I know. Okay.
I will just tell them what I'm gonna do. I'm gonna examine your testis now, Mr. White, and I'll get a chaperone here with me. Is that all right with you? Fine, that's all. I mean, they're there to seek your help and you're helping them. That's fine. I mean, I do appreciate that you want to get the interpersonal skill, but time is essence. So in case like this, I would just get the red flags, any pain, any discharge. Do you notice any weight loss? Notice any lumps? And notice any infection, any fever? That's all. That's the differential done. I will spend more time on clinical.
Yeah, I would just add, as you saying that if you get a station with a symptom, like in this case it's testicular pain, you would think of your differentials before you enter. In this case, you want to rule out torsion, you want to rule out epididymocarditis or any kind of STI. Beyond that, I don't think you need to do anything for PLAB 2. So if you're thinking of these three things, just focus your history on that. Ask them those relevant questions for that. So if you miss sexual history in the station, it's quite important. So you see, if you just keep those three things in your mind, you just ask everything related to that. You've asked it, move on, go to the examination. That's the next thing. So just think about what you want to rule out and focus your history just on those things. Don't ask anything beyond that.
Yeah.
And for interpersonal skill, I did say that you have to be nice, but there are other things where you can add to your interpersonal skill as well. Like just even the simple things like, oh, bless you. That sounds difficult. That sounds frustrating. I'm here to help you. So you don't have to keep asking. Interpersonal skill and being nice to patient is not about taking their lead, because you are still in the consultations where you are taking the lead. So you will tell them what you will be expecting. You will constantly tell them what they will be expecting from you. But you can also say the few things like, addressing the pain, addressing the frustration, that would be O. So you don't have to, can I ask you a question? Like a lot of people go into the station, just say, can I ask you a few questions around the pain? You don't have to. Carry on with Socrates. Just say, first question I will ask, tell me a little bit more about it. And that's all they want to tell you. Carry on with the close-ended questions. Rather than asking them twice or three times any other symptoms, just carry on.
Okay.
All right.
And
Yeah.
also the patients that they're trained to give you a history towards your examination and towards the diagnosis, right? They've been already told what to say. They're not just there to answer exactly what you're saying. So if someone says they're in a lot of pain, it's getting worse, it's out of the blue for me, I don't know what's going on, they're trying to tell you that this is some kind of an acute situation. And you can then use that and move on. You don't have to be very nice with your history. You can say, okay, I can see you're in a lot of pain. Let's see what's going on. Can I start examining you? And you can use that to move on. They wouldn't do that if they've been told it's just a history station and it's something that they, it's something that they need more reassurance with. They will lead you. So take the lead from the patient as well.
But sometimes just a simple smiling at the patients will actually score you points because you've been a nice doctor, as is your own personality. So that's who you are. Shall we move on to the third stations? Would you still like to be our volunteer, Patricia?
Sure, yeah.
Okay. Third station is gonna be straightforward. I'll give you a hint. It's gonna be Sinman because there's no hint on the station.
That's
So
right.
just remember the A to E assessment. Remember what I say just now. All right.
Yeah.
There we go.
Okay, thank you.
So I will be the examiner in this station where you just have to know what to do.
Yeah, thank you. My name is Patricia Xaratko. My GNC number is 7699431. Hello.
Hello, doctor. Can you please help me? I'm very short of breath.
Yeah, hello. I'm Patricia. I'm one of the junior doctors working in this department, and I'm here to help. Just need to quickly check your name and age, please.
I'm James. I'm 40.
Okay, James, could you tell me how are you feeling? What are you feeling?
I can't breathe. I'm really short of breath. I think my asthma is killing me.
Okay, please, James, bear with me. We're here to help you now. I would like to look at the monitor and check full patients' SATs and breathing rate.
Saturation is 78% on room air. Respiration is 32.
Okay, 78%. Okay, James. So very quickly, do you smoke or have any COPD?
I don't have any COPD. I did smoke, but I was told to stop because it was triggering my asthma a lot. So I haven't smoked in a few years now.
Okay. So because you're having a very low oxygen level, so we're gonna put an oxygen mask on you, and we'll put this oxygen 15 liters, 100%, and it's gonna be a high flow through our reservoir mask. Yep. So as my patient, James, because you are being able to talk, so your airway it seems to me that it's patent. So I'm gonna carry on with my assessment. So we're gonna have a look on your chest. So sorry. So I don't know if the patient is exposed, so I need to have a look on your chest. Looking for inspection to see if there's anything visible, and I would like to have a listen as well to the chest.
On auscultations, there are widespread wheeze across the chest.
Okay, so
Patient is unable to complete sentence. Patient is unable to complete sentence in one breath.
Okay. Very well. So I'm gonna give my patient salbutamol 5 milligrams nebulized. So I need to change my sorry, James. Sorry. We're gonna give you some medication to help you talk, to help you breathe better. So we're gonna change your mask for a nebulizer mask, and we're gonna give you some salbutamol 5 milligrams. Yep. And then I would like to check my patient's, I would like to check the monitor.
Oxygen levels come up slightly to 82% on 15 liters.
Okay.
Respiration rate is 25 at the moment.
Okay, yes. So I would like to continue. So James, I'm going to continue my assessment. I would like to request a chest X-ray for my patient, and I would like to do ABG. Oh, yes, ABG. So I'm gonna move on. How are you feeling? How is it helping a little bit, the salbutamol?
I think so. I can't tell yet, but yeah, a little bit.
Just a little bit, okay. So we'll move on to my circulation assessment. Can I have my heart rate and blood pressure, please?
Blood pressure is 120/80. Heart rate is 125.
Okay, so my patient is having some tachycardia. So I will So I will. So James, I'm gonna have a listen. I'm gonna fill your pulse, and I'm gonna take some. I'm gonna put my finger on your chest to check your capillary refill time. And
seconds.
Yep, and I would like to have a listen to your heart as well.
Normal heart sound.
Okay.
Fast.
Can I check my patient's rest and oxygen level, please?
Oxygen level is coming out slightly, 85% of 15 liter. Respiration is still 23.
Okay, how are you feeling your breathing now, James?
It's better. It's a little better.
Okay. Yeah. Okay. Very well. So, okay, so my patient seems to be improving. And then I would like to move on to D. So James, as you are talking to me as well, your conscious level seems to be all right. You're alert. I would like to check your pupils.
Equal. Both
Equal.
people equal.
Yeah.
Just conscious.
Yes. Oh, sorry. I think I would like to go back to C, and I would like to put a cannula. I forgot. So I need to put 2 large bore cannulas on my patient, and we need to have a line and obtain some blood. So we'll request FPCs, USANEs, LFTs. I'm gonna check my patient. Let's see. Oh, I forgot the name of the test.
Would you like to carry on?
Yeah. Sorry. Yes, I will carry on. And then I will check my patient's capillary glucose as well. I will check the monitor.
Oxygen level is improving. Saturation of 89% on 15 liters. Respiration is 22%.
22. Okay, so my patient is improving, so I need to keep reviewing him. How are you feeling now? Oh, sorry.
Heart rate is 130. Carry on.
130. How are you feeling now, James?
A bit better, doctor, but I still feel a bit short of breath.
Okay. Okay. I'm gonna keep examining you. So, what is the heart rate? Sorry, I'm thinking. So sorry.
Okay.
All right.
Yeah. So I will reassess. So I think I'm gonna go and check again. The monitor was okay. So I will need to go to E. So I'm sorry, I felt a bit stuck in here. Because
If you're stuck, what can you do?
Yeah, so I will just reassess, check the monitor again. The patient was feeling okay. And
You don't have to save me all by yourself.
oh, yes.
So if you're stuck, you can call someone for help.
Yes.
Okay.
Yeah.
So yeah, time's up.
I will call my senior.
Yeah. So in the first minute, you knew that your patient's having an asthma attack, right?
Yeah.
And you gave the nebs. That was the first thing. You stabilized. You made sure airway was patent throughout. You tried to stabilize the breathing as much as you could. If you don't know what else to do beyond that for asthma, you can get a senior.
Yeah, I think I got stuck because the heart rate was still high and it wasn't improving.
Yeah, because I was breathless.
Yeah. So, yeah.
Right. So you did the basic. I would say you did the basic management. You kept the patients alive and you keep checking the monitor, but it's wasting your time. I mean, it's consuming your time. But you did prove that you're a safe doctor, but you need to finish the station. You started strong, but you just kind of, I think it's just the nerve that caught you out. So you just kind of swear off slightly. So it's about your confidence. If you know that what you're gonna do, your confidence gonna come in. This is why I've keep mentioning A, B, C, D, E. You go in, airways patent, move on. I would normally reassess again after disability because you don't have time to keep going back and check unless the patient just suddenly crash. But it's not gonna happen in the exam world. So you should know if you are doing the right management. If you know patients got asthma, you give the correct management, patient to get better. As simple as that. So always go back to your ABCD. Even if you're stuck, oh, what should I do? I mean, it's only normal for people to get nervous during the exam. It's not just yourself. Most people struggle with Seaman. So you just, as long as you're systematic, you know A, B, C, D, E well, it doesn't matter what station comes up, you're gonna score well. Like you're gonna excel in the station. So I would strongly advise everyone to go through A, B, C, D, E for your Singman station. That's all you need to do. And then at the end, for the presentation part or for the referral part, like discuss with your seniors, you just have to brief through them what you have done. Patients have meted with shortness of, we've got this maybe 32-year-old gentleman admitted with shortness of breath. I think he's got asthma. He's initially presented with a breathe saturation of 85% room air, and I have given him oxygen. Just run through your A, B, C, D, E slowly with your examiner. That will be good enough. Okay. So At the end, I would say, is there anything else? So I have done these tests. Is there anything else you would like me to? So that's all. Simple.
Okay.
Any questions from anyone? Do you have anything to add, Amanda?
I just wrote some pointers about when you were explaining your A to E in the beginning.
Yeah.
One of the things that you said is don't focus too much on history, but I would kind of say don't focus on it, but do give your patient the first 30 seconds in the SIM-man to tell you what's going on, unless they're drowsy, because they'll usually give you the answer. Especially if it's a sepsis station or something like that, they'll say something's not right. I just don't know what's happening. If they're breathless, they'll usually tell you why they're breathless. If they say, their chest feels heavy or something like that, it's towards cardiac and it's chest pain. They will tell you what's happening. Or if they're just drowsy and they don't know what's going on, it's usually hypoglycemia. So I think just 30 seconds or 20 seconds, give the patient to tell you. They might give you the answer, and that'll help you guide your A to E as well. And just one other thing, which is just very specific to what I went through with my SIM-man, because I thought I was going to fail that station the way I did it. Because I had hypoglycemia and my patient kept going in and out of conscious levels during my A to E. So I wasn't sure whether at one point he was drowsy and I should manage his airway, or one point he was giving me a history. So it was very haphazard. And one of the things I struggled with was to find the cannula, because I said, I think the patient needs glucose. I couldn't find the stick or anything, nor could I said the next thing was 20% glucose IV, and I couldn't find the cannula. I went through all the drawers, and this is just something that could happen to anybody, is if you don't find those things that you're looking for example, you want to change the mask when you put nebs on, when you're physically in the exam, you might actually divert your attention towards finding this right equipment. And it's okay to say you know what to do, but you can't find it and assume you're doing it. So just say, I can't find it. I assume that this is, I've changed the nebs or I've changed the cannula or something like that, and just keep moving forward. The idea is to finish your station and let the examiner know you know what's going on, and to be a safe doctor at the end of it.
Everything will be in the stations. If they want you to have the inhaler, if they want you to look at the operation chart, if they want you to look at the medications chart, it will be on the trolley. So when you go in, just have a brief look through everything. All right. You've done very well. I mean, it's only human's nature to be nervous in practice like this, but it will get better. You just work on the time management and ask the specific questions, which is important. All right, I think it comes to the end of our session.
Thank you very much.
Thank you very much.
Thank you,
everyone, for listening.
Thank you, Patricia, for really being our volunteer for all 3 stations.
Yeah.
I hope it was useful to you. Thank you so much.
It was. Thank you. Thank you.
All right, it would be much appreciated and helpful if everyone could leave a feedback at the end of our sessions, because it helped with us planning the next sessions, what will be important, what will be relevant for you guys. All right, have a good evening and good luck in your exam for those who's doing the exam sooner. And good night. Thank you.
Thanks, Dennis and Amanda. I've put the feedback form in the chat box, and the event was obviously recorded, so it will be in Meadow by tomorrow, so you can all watch it again if needs be. Thank you so much.
Thank you. Bye.
Thanks. Bye-bye.